As you see on your graphic there, one of the diseases that we're talking about now is ulcerative colitis. Ulcerative colitis affects 50 out of every 100,000 people. And ulcerative colitis is one of those diseases not a lot of people know. In fact, it affects 2 million people in America. Here with me is Dr. Michael Van Norstrand. He is from Franciscan Skemp Healthcare and gastrologist there, and of course his graduate education from Mayo Medical School. So he does know exactly what he's talking about when it comes to this type of thing. And Dr. Van Norstrand, thank you for joining us.
Well, thanks for having me.
Let's talk about ulcerative colitis. And not a lot of people know what ulcerative colitis is, do they?
Not a lot of people know about it, but many people know somebody who has it. And most of the people that I talk to, even if they're not seeing me for that problem, they have a relative, they have a friend or somebody down the block who has ulcerative colitis. Because the incidence is significant and it's increasing, actually.
What is the difference between ulcerative colitis and colon cancer?
Well, there is a big difference. Ulcerative colitis is an inflammatory condition where the body essentially makes an immunologic mistake, and it thinks that the colon is the enemy. And so your body's immune system starts attacking your colon, which leads then usually to bloody diarrhea, abdominal crampiness. That's a far different thing than colon cancer, where there may be an immune mistake that's made there. But in colon cancer, you have unrestrained division of cells, which then cause tumors, which then can invade other tissues and cause damage in that way. So they're two different processes. Interestingly, though, ulcerative colitis over a long period of time can make you more prone to having colon cancer.
So there is some kind of a relation there, per se, but not a lot.
There is a relationship in that ulcerative colitis is a distinct risk factor for colon cancer, particularly in younger persons, because it occurs earlier in ulcerative colitis.
Ulcerative colitis, in fact, affects many people, especially under the age of 30, correct?
It does. The incidence of ulcerative colitis is relatively steady over the decades of a person's life. People are more commonly diagnosed with it later in life, as opposed to, say, Crohn's disease, where many people are diagnosed early in life. But nevertheless, we see it in all age groups. We see it in children. We see it in people in their 80s. And it can be of various types. It can involve a small portion of the colon or the entire colon. So it has a wide variety of presentations.
So it affects a wide variety of different people, then.
It does, a wide variety of people.
Men, women, doesn't matter.
It affects men a little more commonly than women, but it affects both sexes. It affects us all races. We used to think of this as a disease primarily of the developed world and of people of Northern European descent in particular. But increasingly now we're seeing it in people of many other backgrounds, Asians. We're seeing it in Hispanic Americans more increasingly. So it hits everybody, and there is not a race of man that does not see this problem.
What are the risk factors with living with Crohn's? Or, excuse me, with ulcerative colitis?
Well, the risk factors of ulcerative colitis, at least to your overall sense of well-being, and that's what people usually want to know is, how's this going to make me feel? How's it going to affect my life? The hallmark of ulcerative colitis is bloody diarrhea. Bloody diarrhea that's associated with abdominal crampiness and people having to go to the bathroom when they really don't want to.
Which is a lot.
A lot. And you know, we define it as mild, moderate, and severe. Mild is less than 4 bowel movements a day. Severe is more than 6. But people who have severe ulcerative colitis, they'll say, Doc, I have to go to the bathroom 15 times a day, and I have to know where a bathroom is every hour of the day. That really affects your life.
And it affects your overall lifestyle because, again, like you said before, you have to be by a bathroom. You have to kind of know exactly where you are pretty much at all times.
You do, and that can be really problematic if you're trying to drive to Madison because you may need to have to go to the bathroom several times along the way.
What can be done to help people with ulcerative colitis to make life maybe a little bit more easier?
Well, the primary treatment for ulcerative colitis, once the diagnosis is made, which is usually made endoscopically, we have to look so we know what we're dealing with, and we exclude other causes, such as infectious problems, is usually we'll start with medication. Depending upon whether it's mild, moderate, or severe, we have a spectrum of medicines which will modify the disease process. If it's mild, we'll use topical treatments in the form of either oral or rectal mesalamine in the form of enemas or suppositories. Ulcerative colitis doesn't always affect the entire colon. In some people it only affects the distal colon, and in those cases we might use a topical treatment like a suppository, or it may affect the entire colon, in which case pills will be appropriate treatment. That's for mild. For people with moderate to severe...
Is that where we kind of get talking about surgery possibly?
Well, possibly surgery, but we still have another step we can go to in medical treatment. We may use immunomodulatory medicines, fancy word for it's going to slow down your immune system, such as Imuran. Can be very helpful in some people. Every time you step up treatment, though, these medicines will have a little higher side effect profile. And so you're always balancing what am I going to do for the patient versus what side effects will be incurred. And finally, when you get to the higher end of the spectrum, there's the biological treatments like Remicade, Humira. Those are the trade names for drugs, infliximab, adalimumab, which actually are a silver bullet that go and take a specific molecule out of the inflammatory cascade called tumor necrosis factor, takes it out of the equation, and shuts down the inflammation. All of these drugs work. They don't work in everybody. There's always people who are unresponsive to everything we do. And then if a person really presents with a fulminant case, and there are people who present that way, where their colitis is so out of control you have to do something and do it fast, the old-fashioned drug IV solumedrol, or prednisone in the oral form, which has been used for 50 years, will work to put these folks under control, and then hopefully we can step them over to something else which can maintain a remission and keep them symptom-free.
What are the main things people should at home maybe kind of look out for? What types of symptoms? Maybe you talked about the cramping and stuff, but and the bloody stool. Is there anything else people should maybe kind of look out for?
Those are the main things. It's amazing to me how long people can live with symptoms and say, well, it's not too bad, I can put up with it. And when you take the history, though, you really do see how resilient people are. And they'll finally come when they've had 8 bloody bowel movements a day for 6 months, and they've just been making do. The hallmark of ulcerative colitis is diarrhea that's bloody, that's crampy, and it's chronic, and it does not go away. That's the thing they should look for. But warning symptoms are when people start getting increasing abdominal pain.
Yeah.
That is really a warning.
Cures? I mean, have we wrapped this up? A cure? Is there any kind of cure for people? Is it something that people just are going to have to learn to live with?
There is no cure for it, but we don't know exactly what causes this. The immune system has made a mistake. There's a lot of basic research going on. We do know some of the key players in this mistake that was made, but we still don't know how to put it together so that we can flip the switch back again and get them back to where they were. So all of our treatments are designed to put the person in remission, so as near as they can tell, they feel normal, and then keep them there as long as we possibly can. Ultimately, there is always a subgroup of people that are going to need to have surgery for this.
And people can live a normal, healthier life even though they have this.
Yes, they can. That is our goal. That is our goal.
Dr. Van Norstrand, thank you for joining us.
Well, thank you for having me, Rick.
All right.
I appreciate it.
We'll be back right after this.